Cash USMLE style question. Eisenmenger Syndrome. A 23-year-old woman presents to the clinic with progressive shortness of breath, fatigue, and cyanosis. She reports a history of a heart murmur diagnosed in childhood, but she did not receive surgical correction. Physical examination reveals clubbing of the fingers and toes, a loud P2 heart sound, and polycythemia. Which of the following best explains the pathophysiology of this patient's condition? A. Increased left to right shunting leading to volume overload of the right heart. B. Obstruction of pulmonary blood flow due to right ventricular outflow tract narrowing. C. Chronic pulmonary hypertension causing reversal of a pre-existing left to right shunt. D. Failure of endocardial cushion fusion resulting in atrioventricular septal defect. E. Abnormal migration of neural crest cells leading to a single arterial trunk. Chronic pulmonary hypertension causing reversal of a pre-existing left to right shunt. Explanation: Eisenmenger syndrome is a late complication of an uncorrected congenital left to right shunt, e.g. ventricular septal defect, VSD, atrial septal DSD, or patent ductus arteriosus, PDA. The persistent left to right shunting leads to chronic pulmonary hypertension, causing vascular remodeling and increased pulmonary vascular resistance, PVR. Once PVR exceeds systemic vascular resistance, SVR, the shunt reverses to a right-to-left shunt, leading to cyanosis and polycythemia. Key features of Eisenmenger syndrome: initial left-to-right shunt, increased pulmonary blood flow, progressive pulmonary hypertension, irreversible pulmonary vascular changes, right ventricular hypertrophy or VELOPs due to increased afterload, shunt reversal right-to-left, cyanosis and clubbing, polycythemia, compensatory increase in RBCs due to chronic hypoxia, loud P2 due to pulmonary hypertension. Why the other answers are incorrect? Just A. Increased left to right shunting leading to volume overload of the right heart. Describes early stages of congenital shunts, but does not explain the cyanosis and shunt reversal. B. Obstruction of pulmonary blood flow due to right ventricular outflow tract narrowing. Describes tetralogy of Fallot, TOF, which presents with cyanosis in infancy, not progressive cyanosis in adulthood. D. Failure of endocardial cushion fusion resulting in atrioventricular septal defect, seen in Down syndrome, but Eisenmenger syndrome is a consequence of an unrepaired shunt, not a primary developmental defect. E. Abnormal migration of neural crest cells leading to a single arterial trunk. Describes persistent truncus arteriosus, PTA, which presents in infancy with severe cyanosis. Chat key takeaways. Eisenmenger syndrome results from an uncorrected congenital left-to-right shunt, VSD, PDA, leading to irreversible pulmonary hypertension and right-to-left shunting. Progressive cyanosis, clubbing, and polycythemia are characteristic features. Loud P2 and signs of right ventricular hypertrophy, RVH, are common on exam. Surgical repair is not an option once irreversible pulmonary vascular damage has occurred. Would you like